Good morning, everybody. We're going to talk about some topics this morning that are not always the easiest topics to talk about, but that I think most of us find at some point in our caregiver journey that is really helpful if we're aware of this information. Most of us are familiar with the concept of living wills. That's one form of advance directive, which is telling somebody ahead of time what your desires are for end of life care and treatment. What we're going to do today is go beyond the living will to some other forms of advance directive, which are DNR, which is do not resuscitate, and most forms. Both of which are medical orders for the end of life care. Start out with a disclaimer. The MOST form, which stands for Medical Orders for Scope of Treatment, is North Carolina's version of a national form that's called POLST, P-O-L-S-T. POLST used to be an acronym for physician orders for life-sustaining treatment. It has now been recognized enough that in the latest research that I'm doing, POLST stands alone. It's no longer an acronym because it is recognized well enough in medical circles. Many states, like North Carolina, though, have adapted in some way the national form, but all the forms cover essentially the same information. Today, I'm going to be talking about North Carolina's form specifically because that's the form I know. But there is a website listed here that will give you information for any state. If you go to this website, you can click on your state and it will tell you what your form is called, how to get more information on it, and who the contact person is in your state for that information. Let's talk about, to start with, a little bit of the difference between living wills and the DNR MOST forms. Living wills are typically, as I said, prepared in advance of an illness, and it states one's general preferences about what they would like done. In other words, their wishes for what might happen at end of life for them. It's recommended that anyone over 18 years of age have a living will, and that's certainly not something we think about in the general public. Those documents are typically prepared by an attorney, but they can be done by the individual, and you will find formats online for doing your own living will. One of the things that's included in a living will is the name of someone who can act as your healthcare power of attorney. That person who can make decisions for you if you're unable to make decisions. It's critically important, whether you have a living will or not, that you have someone who can act as your healthcare power of attorney and that that person had been formally named, because you can't anticipate, no matter how hard you think, all the things that might happen and the decisions that have to be made towards the end of life. A living will has to be signed by the individual who's written it, and it has to have 2 witnesses and be notarized. It's a document that you normally keep with you and that your physician, your primary physician, any hospital that you are affiliated with, and perhaps the person who's your primary or who's your healthcare power of attorney also needs to have a copy of. When we talk about DNR and MOST forms, they are most current forms. They address specific current desires for treatment. Typically, these are forms that would be initiated when a physician or a family member can answer the question, Would I be surprised if this person died within the next year? So that's usually the questions that's your tipping question for when it's time to discuss these forms. It's recommended again for individuals in their last year of life. It's prepared by a physician, a nurse practitioner, or a physician assistant based on the desires of the patient at that point in time or his legally responsible individual if the patient is unable to make decisions. It must be signed by a medical provider, by the patient, or his legally responsible individual. The MOST form is one of the few forms that is actually medical orders that requires the patient's or the legally responsible person's signature in order to be effective. DNR and MOST forms promote patient autonomy by documenting the treatment preferences and converting them into medical orders, much the same as other orders that appear in a chart or maybe as a prescription. We think about a prescription that we have filled as a physician's order or a medical provider order. And the DNR or MOST forms fall into that same kind of category. It clarifies treatment intentions so that it minimizes confusions, typically when there's a crisis situation. They also help facilitate appropriate treatment by EMS personnel. If you have only a living will and there is a medical emergency and EMS is called, there's usually not time to figure out what's in that living will that the patient wanted to have done in this situation. In addition to that, again, the living will is much more vague in terms of the information that it contains. If there is a DNR or MOST form, again, those are considered physician orders so that it is very clear what is to be done in this situation. And both the DNR and MOST form meet HIPAA requirements so that they can be transferred from facility to facility and be acceptable. And both are considered, for that reason, portable medical orders. What are the ethical considerations that we need to think about for healthcare decision making? And this is important for, I think, particularly us as caregivers for persons with dementia, because many times we are going to be the ones making these decisions in the last year of life. The first is respect for autonomy. And that is either the autonomy of the patient, himself or herself, or of the person who is that healthcare power of attorney. One of the components of autonomy are being able to make one's own decisions and have those decisions followed is informed consent. So it's really important, and you will see how this occurs throughout the process of the MOST form, that families be aware, or the healthcare power of attorney or patient be aware of all of the pros and cons of the choices they're making. Also, we always have to look at the benefits of the treatment versus the risk, and we'll talk more about that when we talk about each treatment. And remember that for medical care providers, one of their parts of the Hippocratic Oath is to do no harm. Okay, this is what a do not resuscitate order looks like. And as nearly as I can tell, they're pretty much the same in every state. This is the actual North Carolina form. It's on this bright orangey yellow paper and is only valid if it is on the correct color paper and has the correct original signatures on it. It's not an order to withhold all treatment from a person. It only talks about CPR or cardiopulmonary resuscitation, those procedures that are implemented when a person has no pulse and is not breathing. For this form, there can be multiple originals. What I did when I completed one of these for Roy is that there was an original that stayed in my car all the time because I was still taking him out for some doctor's appointments. There was one at the facility where he was residing at the time. And I also kept a copy at home. So they have to all be originals again, but it's a pretty simple order to ask somebody, a medical care provider, to fill out several different times so that you always have it available. It has the effective date, if there's any expiration date, and in most cases there's not, the patient's full name, the signature of the physician assistant, or nurse practitioner who's actually giving this order, their printed name, address, and information on how to contact that medical care provider. One thing about do not resuscitate orders is that if you ever have one or know someone who does, and something happens that they want to rescind that order, then you need to make sure you track down all of those originals and tear them up. That's perhaps a little bit of a disadvantage of having multiple copies. Okay, I want to spend most of the time, though, talking about the MOST form. It's more comprehensive than the do not resuscitate order. It includes 4 sections. Section A addresses CPR. So that part is in some ways a duplicate of the do not resuscitate order. Section B addresses general medical interventions. Section C addresses the use of antibiotics, and Section D addresses medically administered fluids and nutrition. And we're going to talk about each of those sections in a little more detail. Completing a MOST form requires an in-depth discussion between the medical care provider and the patient or his legal representative to make sure that all these options are understood in light of the patient's diagnosis and their current medical status. In order for the form to be effective, and this is the top half of the form, the identifying information in this part of the form, as well as an effective date, and the effective date is the date that it's actually signed, the medical provider's signature and date, and the patient or the patient representative's signature all have to be filled in. And you'll see where some of those other locations are in the form as we go along. This is Section A. It has red around it because Section A and B both have some red because they are the first areas that if there's an emergency or if EMS is called, they would look at. And Section A deals with cardiopulmonary resuscitation or CPR. Again, this applies only if the patient has no pulse and is not breathing. And attempt CPR or do not attempt CPR. So this part is pretty much a duplicate of the DNR form. Let's talk a minute about CPR though. CPR is really not like what we see on TV from several perspectives. First of all, it's a pretty brutal process. And secondly, many people do not survive CPR attempts. It's a long process. It involves chest compressions, during which the person who's providing those chest compressions has the heels of both hands, like this, on top of each other, on top of your sternum or your breastbone. And in order for CPR to be effective, the sternum has to be pushed down about 2 inches. And that has to happen about 100 times a minute. So that's pretty significant force repeated over and over again in that process of chest compressions. If you want to think about how fast 100 compressions a minute is, the best way to do that is to think about the song that when one's training in CPR, they're told to sing in their head as they're doing chest compressions to make sure they're doing an adequate number. And ironically enough, that's the song Staying Alive. And I think most of you are probably familiar with that song, but that's a very fast rhythm when you think about it. In breathing for someone, air is forced into the lungs, and most typically, one of the first things that's done is that a plastic tube or a breathing tube is inserted down into the throat so that we make sure that that airway is open so that air is actually getting through to the lungs. There may be electrical shocks. There's always an IV started because there's a need to get certain medications in to support this process. And typically the person who has CPR ends up in the hospital in the intensive care unit if they survive the CPR. For adults who are 67 years of age or older with one or more major chronic illnesses, that includes such thing as advanced lung disease, advanced cancer, or advanced dementia. Those people live an average of 3.9 months longer after they have CPR. The average survival rate for all adults, if CPR is performed in the hospital, is a little less than 25%. So that means that 75% of adults that's performed in the hospital do not survive CPR. Of those who do survive long enough to be discharged home, at least 28% of those will have significant neurological damage from the lack of blood flow to their brain and other organs during the time that the CPR was being performed. If CPR is done out of the hospital, the survival rate's much lower because you don't have all the medical equipment readily available. And in that case, the survival rate is somewhere between not quite 8 and not quite 10%. The rates of survival decrease with age, with poor functional or cognitive status, and with multiple chronic illnesses. Let's talk about the complications from doing CPR on an individual. You may have guessed what some of these are already from my description of CPR. About 97% of individuals who have CPR will have rib fractures. About 43% will have fractures of that breastbone or sternum because of the amount of pressure that is being put on that. 59% will have bruising of the chest. 30% will have burns from the defibrillator or those shocks that are used to help restart the heart's rhythm. Up to 50% will have some degree of permanent brain damage from lack of oxygen. And then there are other possible complications such as bleeding in the chest, damage to the trachea or the esophagus as the tubes put down, lung damage, damage to the mouth, lips, and teeth. So when we think about CPR, and certainly what we see on TV, these are not the things that we usually think about as being side effects of that particular procedure. Okay, the next section of the MOST form is the section in North Carolina that's called medical interventions. And these occur if the patient has a pulse and or is breathing, but there is still a significant event of some kind going on. This might occur in the situation of someone having a stroke, having collapsed at home, and we aren't sure what the reason is, but by the time anyone gets there, they're conscious. There was never any question about whether they stopped breathing or not, or if a person hits their head but is still conscious and doesn't require stitches. This section's divided into 3 subsections. The first one is called full scope of treatment. And the goal in this section is to have everything done that's medically appropriate and possible to save someone's life. That includes calling 911, putting in that tube that goes to the lungs, maybe putting them on a mechanical ventilator or a breathing machine at the hospital, using those shocks to either stop an erratic heart rhythm or to restart a heart, giving IV fluids, transferring to the hospital, admitting to ICU if that's indicated. And if you choose to have full CPR, this choice is almost automatically appropriate, because you can't do full CPR without having these supporting actions involved in that. The next one says limited additional interventions. Some states label this section selective treatments. And the goal in this is to treat medical events that have a high likelihood of being able to be reversed. What is done may include IV fluids, monitoring the heart, oxygen that is administered maybe by CPAP or BiPAP, which puts a little bit of pressure behind the oxygen, but is not the same as the pressure that would be on there in a ventilator. And many of us are accustomed to CPAPs and BiPAPs because those are the machines used at home for sleep apnea. Suctioning, transfer to the hospital, but maybe not into the intensive care unit. And this, again, might be the kind of treatment that one would have if they had pneumonia. And it was expected that the pneumonia could be cured with antibiotics and with some support for a period of time. The third section, on this is comfort measures. And the treatment goal in this is to maximize comfort for the patient and allow death to happen naturally. It includes keeping a person comfortable, giving them medication to make sure they stay comfortable, positioning or wound care to help with that, perhaps oxygen, suctioning, getting any secretions out of their mouth if they're having trouble spitting those out themselves, but does not include going to the hospital unless comfort needs cannot be met in the current location and it requires hospitalization to do that. There's also a place here for other instructions, and that might be a place that a medical care provider would fill in any instructions for care that might be particularly pertinent to your individual's diagnosis. Let me give you 2 examples from my own experience as a caregiver about when one or the other of these situations might be appropriate to use. I had a MOST form filled out on Roy for, probably almost 2 years before he died because his medical status was so up and down. And what I had opted to do based on discussions with him when he was still able to have these discussions was to go with comfort measures only. There were 2 times that came up with different responses, appropriate responses each of those times. The first time he had a stroke, and he was in a 6-person family care home. And fortunately, they called me while the nurse for the family care home was in the process of getting there. And they knew that I did not want him moved. And the nurse got there and insisted that he go to the hospital. So the nurse and I had a fairly heated discussion on the telephone, with my reminding her that these were medical orders. They were signed by a physician and they had to be followed just like any other medical orders, that she could not unilaterally decide to disregard them. The reason I did not want Roy moved at that point in time is that he was not uncomfortable. We could handle keeping him comfortable where he was. I knew that there was no treatment that they were going to be able to provide him. For strokes, you can either have a person who's having a bleed into the brain of some kind, in which case there's not a whole lot you can do but monitor it, or you have a person who has a clot in a vessel in their brain, in which case what typically happens is the use of clot busting drugs. Roy had had a significant fall several years earlier and had bled into his brain as a result of that fall and could not have the clot busting drugs. So the bottom line in this situation was, what was going to happen at the hospital that couldn't happen where he was? As long as we could keep him comfortable, nothing any different was going to happen for him to be in the hospital. So we ultimately, when EMS got there, the staff pulled out the MOST form for them and they backed off and left him where he was. At that point in time, I happened to be at my parents' a little over 2 hours away. So it was a good thing that I had the form, because I was not able to get there as quickly as he would have been moved. The other situation in which we used this form was when he had a massive heart attack, which is what he ultimately died from. And the difference in that is that because he was having so much pain, we could not keep him comfortable in the facility. So even though what we wanted were comfort measures only, what we had to do was go to the emergency room in order to be able to get the IV medication that he needed to keep him comfortable during his last hours. So that's two kind of different ways or different times that we use that form. And even though we had comfort measures checked, we did something different in each of those cases based on the circumstances. Section 3 talks about antibiotics. Do you want to use antibiotics? Do you want to limit the use of it, or no antibiotics other than if you have to have them to relieve symptoms? Let's talk about antibiotics in late-stage dementia. There's a study, and actually there have been several of them, that found that about 40% of those individuals who resided in nursing homes with late-stage dementia got antibiotics at some point during their last 2 weeks of life. The strongest antibiotics are given by IV. And if you have a person with dementia, they are typically at this point not able to cooperate and leave an IV in place. So what then happens in order to keep an IV in place to give the antibiotics is that you either use medication or physical restraint to keep that IV in place, which is not the most comfortable thing either. And what we know from studies is that antibiotics can extend life in these final phases, but only by a couple of days. One of the things that happens most frequently in the final stages of dementia is that a person will get pneumonia. And it was once thought that pneumonia was called the old man's best friend or the demented patient's best friend because it was an easy way to die and did not create a lot of discomfort. What we found is that there probably is some discomfort associated with pneumonia, because anytime you have difficulty breathing or getting your breath, there's some discomfort, and there's frequently fever involved. However, antibiotics do not appear to reduce any of that discomfort. Usually Tylenol alone will control fever and reduce discomfort enough that the person is comfortable, even when they have pneumonia, without the use of antibiotics. Okay, the next section is medically administered fluids and nutrition. And one column deals with IV fluids, the other column deals with feeding tubes. There's the ongoing indefinite use of IVs usually means that feeding tubes will be considered. So if you're concerned about hydration, that's likely again going to happen in a hospital and is not one of those things that keeps going on and on and on without there being discussion of feeding tubes. And usually a feeding tube is placed initially through the nose, down the throat, into the stomach. But after about 2 weeks, most physicians recommend that there be a surgical insertion of a feeding tube, which is usually into the stomach or the intestine. And you may have heard someone talk about a PEG tube where the feeding goes straight into the intestine. It might be appropriate to use an IV for, again, what seems to be a temporary situation. For example, a person has significant diarrhea and seems to be getting dehydrated, to see if the IV will in fact reverse that process or give their intestines a little bit of time to heal, so that they can recover somewhat on their own. Let's talk a little bit about dehydration, though, in the light of end-of-life care. Dehydration is a natural process that's associated with terminal illness. We know that decreased fluid intake makes the work of the circulatory system easier. It prevents swelling of the feet and ankles. And it also helps prevent accumulation of fluid in the lungs, which in turn makes breathing more difficult. Dehydration is not painful. In fact, as one becomes dehydrated, their body releases endorphins, which are those feel-good hormones that we get from a runner's high or exercise or other very pleasurable experiences. And those help promote comfort and restfulness in a person who's dehydrated. The use of IV fluids has not been shown in studies to increase the quality of life or to extend longevity. What about tube feedings? As I said, for tube feedings, the tube's inserted down the throat or into the stomach or intestines. If it is the stomach or intestines where it's inserted, that requires a brief surgical procedure. What we know is that tube feedings at end of life do not help people gain weight, become stronger, or regain any of their skills. Tube feedings don't help to heal or prevent those pressure sores. And there's no good evidence that people live longer with a tube feeding than those who are fed small amounts by mouth. In addition, going to tube feedings means that you deprive the person of the joy of tasting food and the social interaction that frequently goes along with feeding someone. What are complications of feeding tubes? You can have bleeding, infection, or skin irritation around the tube, nausea, vomiting, and diarrhea. We don't usually think of that, but it takes a while for many people to adjust how much of the liquid feeding they get in the tube at one time, what kind of feeding is best. There's several different formulations. And so you may, in fact, have a period of time where vomiting and diarrhea are issues. And certainly the vomiting increases the likelihood that the person will aspirate what they're vomiting up into their lungs and create a setup for pneumonia. One of the complications is that the likelihood of the person developing pressure sores increases. Again, because they have to be more mobile in the bed for the tube feedings, and may require the use of chemical or physical restraints to be able to keep the tube in place. Again, more likely to spit up food and aspirate or pull that food into the lungs. And because we're continuing to put fluid and food into the body, it increases the likelihood that there's too much fluid, and that may result in swelling, more demand on the heart, and more fluid in the lungs. Okay, the next section of this form is who did I discuss this? As the medical provider, with whom did I discuss this form? And the listing that appears here is the listing in order for North Carolina of who's consulted when decisions have to be made about a patient and a patient is not able to make those decisions himself or herself. Obviously, the patient's the first choice. The parent or guardian, if the patient is a minor, that healthcare agent, healthcare power of attorney, a legal guardian of the patient, and then it goes down the line. So this part is likely to be different in different states, depending on how they establish who can make decisions for the person if there's not a guardian or a healthcare power of attorney. If the patient is able to make and communicate, make his desires known and communicate those to the healthcare team, he is the only person who can sign this form. Then the last part of the, and this is the front of the form, there's some things on the back of it, is the signatures. And you have to have, again, the signature of the physician, PA, or nurse practitioner who is writing this order, the date, their contact phone number, and printing their name to make sure that it's legible. And then the patient or patient representative, their name, their signature, and their relationship to the patient. The signature of, in most instances, the medical signature that's on here should be the same as that person who discussed the patient's condition and reviewed the form with the patient or the family. Although in some instances, all of those things can be reviewed with the family by someone who has been trained to do so, and there be a physician then who actually signs the form. There's no witness signature required on this. And then on the back of this, it talks about the HIPAA disclosure to other healthcare professionals and the contact information and who prepared the form. So again, just some general information on how this came to be and what has happened. Then there's a middle section that gives some directions on things. And then on the bottom of the back page, there are review dates. One of the things that is encouraged with this form is that it be reviewed regularly as a person's condition changes. Frankly, I'm not sure that a review is what I would want if there were a change, because you're going to take the form if there's a change and rip it up. So I'm just not sure when this would be used unless it was to document that it had been reviewed again and that the patient or the healthcare power of attorney or that legally responsible person did not want any changes on it. The form can be revoked by destroying the form, putting a line through it and writing void, or indicating in this section that it has been revoked. For the MOST form, it is preferable that there only be one copy of that form, one original. And typically that form is going to reside wherever the patient is. The reason for only having one original is that if there are changes, because this form has so many more options for where changes can be made, if there are changes, then it's difficult to track down the form and figure out which is the latest one. If there is a conflict, if a patient has both a DNR and a MOST form, and there is a conflict for cardiopulmonary resuscitation between the two forms, the form that will be honored is the form with the latest date on it. If someone does not have these forms, then they will automatically receive what's called the standard of care treatment for whatever problem, which means that they will get whatever treatment someone has who has this problem and typically gets treatment for it. And in an emergency situation, that means doing everything possible to attempt to save the person's life. So how are the DNR and the MOST forms alike? A copy of either of these forms is not valid. It must be originals, and they must be on the appropriately colored paper. Again, for the DNR, it's that kind of goldenrod yellow. For the MOST form in North Carolina, it's that bright pink I've been showing you. Both forms are intended to be portable to travel with the patient to multiple settings. They are medical orders signed by a medical care provider that are to be followed by EMS and other healthcare providers that are involved in the care. They must be signed by a physician, nurse practitioner, or physician assistant. And if the patient is at home, they should be posted over the bed, on the door to the person's room, or on the refrigerator, somewhere that are that's easy to find. I've asked myself many times what might be the purpose of a MOST form for a person who is still residing in the form, or in the home, excuse me. And I think it is a backup if the caregiver is not in the home at the moment. That person who has the healthcare power of attorney is not in the home, and something happens while there's a paid caregiver or another family member there, and that person wants to follow the instructions of the healthcare power of attorney, then it would be helpful to have these in the home. I think it's particularly important and helpful to make sure there is a MOST form for anyone who's in a facility, whether that be someone who's going to reside there or who might be there for rehab but fits the criteria for that not being surprised if death occurs within the next year. But both of these forms are available in all states. They're things you need to discuss with your medical care provider and that you need to be aware of as you plan and think about those last months and days for the person that you care so much about. Okay, let me turn this screen off and see if there are any questions.